All right, well, hello and welcome to this most recent episode of the Akkad and Coco Report. Today, we're lucky to have Dr. Greg Gonzalez visiting us. Dr. Gonzalez is famous because he has a Wikipedia entry,
Yeah.
which I learned all about him. He grew up in New York, was an AIDS activist, and did a lot of amazing work. Spent some time in South Africa, championing policy making there. And ultimately now is joined the Yale School of Public Health in 2017, and he is affiliated with the Public Health Modeling Unit there, also the Yale Program in Addiction Medicine, and he has quite a massive Twitter following. He's very active on Twitter, and that's where I kind of ran across some of his tweets on the COVID epidemic, and he has a lot of strong opinions on what we should be doing. And I thought we would be great to have him kind of come on and tell us more about what he thinks. So thanks again for coming on.
Anytime.
So, Dr. Gonzalez, I guess the first thing I was wondering we could chat about, the modeling for, infectious disease models. And there's been a lot of different, modeling that's been done. There's been a lot of policy changes that have happened because of modeling. How are you, how do you think the modeling community has done?
So, there's a diversity of modelers, right, out there. I'm in the public health modeling unit at Yale, and we have, I'd say, two or three people who do sort of straight up disease modeling, which everybody has seen sort of on the front pages of their local newspapers, even, which
Right.
never happens. And people who do other kinds of things like cost effectiveness analyses. I tend to do sort of operations research based analyses. So there's lots of kinds of modeling that's sort of floating out there. The ones I think you're referring to are the models that have come out of Imperial College of Medicine, or the Institute for Health Metrics at the University of Washington, that have tried to sort of set some bounds on the magnitude of infections and deaths around the coronavirus epidemic. It happened with every epidemic. It happened with Ebola, and it happened with COVID-19. The range of model predictions is pretty wide, and it's always because you're parameterizing a model without any data when you start off. And so the initial estimates are always sort of wide enough that you could drive a truck through. But I think in a qualitative sense, I think they all sort of projected that we would see massive amounts of deaths and infections worldwide, and including in the US. And, if it was between 60,000 and 200,000 potential deaths, I think we'll probably fall somewhere in the middle when this is all over.
Yeah. It seems like the IHME models, certainly from a death standpoint, certainly are not off by orders of magnitude. It does look like the Imperial College model, which I guess is an SIR model, that had a really wide prediction interval, if you will. I think they estimated for the US 1 to 2 million folks dying, and that is that a function of you referenced the Ebola models and how they kind of performed. Is that a function of just SIR models not being that great in terms of modeling what actually happens, or?
Well, I mean, just think of weather prediction. It's just like, predictive models are, I can't remember where Yogi Berra said it, like it's very difficult, it's difficult to predict, especially about the future. And then so the Imperial model was based on no social distancing. It was based on early projections of different parameters in the model. I think Imperial's coming out with a new set of projections for all 50 states imminently, because I've heard little bits of rumblings from over there. Are trying to sort of refine their state-based estimates. So yeah, they were the sort of most scary projections compared to the IHME model, and they're very different models. IHME is a statistical
Right
model.
So,
it's fitting a line and fitting a curve, where the Imperial model, the model coming out of Harvard, the models coming out of Columbia, other places, are SER models that are sort of compartmental dynamic models that really sort of trade in the biology of transmission and personal
Right.
interactions in terms of disease progression.
Right. It seems like the HME model, like you said, it's a little bit of a curve fitting exercise to kind of what's happened, what happened in Italy, what happened in Spain, and then it's constantly updating based on what the trajectory of deaths is here. So one of the interesting things with the IHME model that's kind of relevant, that a lot of us are talking about is how they came up with their estimates for number of hospital beds that are needed, how many ventilators that are needed, and because they were kind of a model that wasn't biological, biological, and didn't have a lot of the estimates that or the assumptions that an SIR model kind of rests on in terms of what's the infection fatality rate, what's the case fatality rate, what's the R naught, which is super hard, especially when you have something that's exponential to try to model and get close. The IHME model, of course, is just kind of trying to model trajectory of deaths, and then kind of working backward from deaths to get to how many hospital beds you may need, or how many ICUs you need, or how many vents you need. And it turned out that the IHME model was off by a fair amount in terms of how many beds and how many ICU, and how many vents and stuff you would need. Is there something to learn? I don't know if in your discussions, is there something to learn from this in terms of trying to figure out in the future how we can be better at predicting on that front? Because those have some really large implications in terms of what one does as a society, or what one does even as a hospital, right? In terms of trying to have the have what you need and project forward 2 weeks, right? So I was a little surprised in terms of how far off the IHME model, for instance, was in terms of how many vents or how many ICU beds New York would need, for instance, right? That seems to be such a wide gap there that I wonder what may have gone wrong, and what we can learn going forward.
So I am not a compartment. I don't do disease modeling per se like this, but looking at Ebola and now looking at COVID-19, I think maybe the use for these kinds of models are not in sort of new epidemics in real time. One is because you don't know very much about the disease, you don't have very much data to parameterize your models. What you see models doing well is like thinking about, if we're thinking about vaccine preventable diseases around the world, what kind of trade-offs do we have to make given assumptions about the prevalence and incidence of certain diseases, the sort of basic biological parameters that we're talking about. I think it's really hard to do prediction in real time. I mean, it's very interesting. I've been talking to a bunch of people I've been filling out a lot of declarations and affidavits for prison cases, getting people out of prisons, along with a lot of clinicians as well. And some people said, can you do a model that can tell us like how bad it's going to get in prison? And I just say, very bad. I mean, it's like sometimes you need a model to tell you what's going on, and sometimes you can sort of look behind you and see what's happening. I think a lot of the ICU bed, hospital capacity stuff is that, remember, these models are parameterized on a national basis or even on a state basis. They're not for like a hospital system or a city often. And with all these moving parts, as all this data is coming in, I think a lot of pressure is put on the models when their use isn't in sort of these acute, fast-moving situations. I think it's much better to think about it as something to sort of do these larger exercises to think about how do you allocate resources and what's going to happen, rather than sort of a crystal ball to tell you what's going to happen in your hospital tomorrow or what's going to happen in your state tomorrow. I think you get crude estimates. You're not going to get something that's very refined.
Do you get the sense that when we started this process, the idea was to try to get the number of fatalities to be as low as possible, or was the idea to try to not overwhelm the healthcare system? There's this constant divide that you hear now. It's like, well, what is our goal? Do you feel like that goal has shifted over time, or do you feel like we've had the same goal throughout? And I ask that, it's a related question because how do we know whether we're going to overwhelm the healthcare system? It seems very, as you're saying, it seems very hard in real time to be able to figure out, are we going to be able to overwhelm it or not?
Well, I mean, so the American epidemic occurred with some sort of previous history of what was happening in China and Spain and Italy. And
Yeah.
I think, I just saw something on the New York Times or some website just now about New Zealand saying they have eradicated the coronavirus, which is not where we're going to go. I mean, it's pretty clear when we were in February and March that it's no worse than the flu, all the sort of down our inability to test, that we were never going to be New Zealand, right? We're going to contain, eradicate, and move on and keep ourselves from having any sort of subsequent outbreaks. I think we were always in damage control. And the question was like, how much like Italy were we going to be, right? And, if you live in New York City, the worst case scenario did occur. A lot of governors and mayors are like, we didn't overwhelm our ICU capacity in our state or our city or our town. But it's clearly, we did have a sort of diverse epidemic in the US in which there were certain cities in which ICU beds were in desperately short supply. And I think there's still cities and states struggling with this right now.
Absolutely right. The other
let me ask you just one question here. So there's, as you notice, such a variability in the U.S. When we say we're not going to be able to get to the point where New Zealand is, isn't it conceivable that certain communities or certain states in the U.S. could, hope to achieve the same, or is it a legal sort of impairment to allowing states or communities to have to lock down their own or to set their own policy?
So public health in the U.S. is all state and local. It's there's some powers at the federal level, but all the sort of rubber hits the road in terms of testing, contact tracing, isolation at the state and local level.
Right.
Carlos Del Rio, who's from Emory University School of Medicine, infectious disease doctor down there, said the idea of sort of clamping down and being successful in one state, given sort of a lackadaisical attitude in other states, is like having a peeing section in a swimming pool. It's unless you're going to contain it within a sort of national context, it's very hard to think that, New York is not going to suffer from what New Jersey does, from what Pennsylvania does, what Delaware does.
So in essence, it's these interstate commerce laws, perhaps, that in a way would prevent one state from isolating itself from the rest of.
Yeah, I mean, and that's why you see the governors like in the Northeast, Midwest, and on the West Coast sort of gathering together to say, can we do all this together? Because I think they understand the sort of mutual independence of their fates.
So how will New Zealand manage to stay COVID-free given that? I mean, it almost seems like they would have to kind of, given that it's a pandemic and it's spread global, it's all over. Are they going to have to? It sounds like they're going to massively restrict any travel into New Zealand if they want to try to avoid this from happening.
Or you come into New Zealand and you're in 14-day quarantine.
Yeah, right.
I'm sure the Prime Minister of New Zealand realizes that they can't sort of seal off. Well, you could seal off. It's an island,
right.
So but I think it's my sense is that for these countries that are sort of getting close to eradicating, they're going to be like 14-day quarantine, keep testing in the community. Yeah. They're going to do everything that they've done right before. But I assume, Prime Minister Ardern is in it for the long haul. I don't know how long the long haul is going to be, because we've seen in Singapore and other places that even places that have sort of cracked down hard on the virus are seeing, new cases pop up. A lot of them are imported, right? A lot of them are coming from international travel and business travel.
Right. So testing will get us out of this mess, apparently. How confident are you that we would be able to? Because it sounds like a lot of the public health folks feel strongly that scaling up testing to some level in the United States will allow us to, I guess, effectively isolate and contact trace. Is that the general thought?
Yeah, but it's not, it's like if you're a physician, you want to be able to understand what's going on across your patient's body, and testing its way we understand what's going on across the sort of body of the American epidemic, and figuring out where the hotspots are that are allowing the virus to flourish, where they're hiding lingering cases. And this is what New Zealand and South Korea and others have done, is basically to use testing as a way to flush out the magnitude and the scope of the infection across their countries, and then chase down every case, isolate them, find out who their contacts are, and isolate them. I mean, this has been like since 1870 in the UK. There was I think it was the Vaccine Resisters League, which doesn't make me happy, but like they didn't want to do any of sort of the cowpox proto-vaccination, and did case identification, contact tracing, and isolation to rid their community of Leicester, England, of smallpox. And that's what we're doing now, is essentially, 150 years later.
Do you think that this particular virus presents difficulties with that, in part because there's a belief that there's transmission that happens before you're significantly symptomatic? I know there's some debate about whether you can be truly asymptomatic or whether you're just pre-symptomatic. But the point is that, you're not, it's not like Ebola or not like SARS, CoV-1. It seems like there's more transmission that may occur in that pre-symptomatic phase. Does that make contact tracing, does that make testing much, much harder to do?
It doesn't make contact tracing that much harder to do. It just, contact tracing is always assuming that if I'm infected, I'm going to tell you all the people I've seen for the past 2 weeks, and you're going to go talk to all of them, and you're going to test all of them, whether they're symptomatic or not. I mean, it's really like shoe leather epidemiology. In the context of a healthcare setting, people are getting tested because they're symptomatic. In the context of contact tracing, you're going to be tested because you knew me and you spent time with me and you're an infection risk. And whether you have a mild case or an asymptomatic case, you should be, unless you're really, really early in the infection, you should have recoverable RNA to give us a diagnosis if you're positive, so we can chase down the rest of the contacts.
Right. So if you're symptomatic, again, some of the issues with this particular disease is that it's a in the respiratory tract, the sensitivity of the RNA test is not that high. It's very hard to to pinpoint exactly what it is, but certainly in the China series, for instance, about 40% of the folks that they said had COVID were test negative. So if you assume, 50, 60% sensitivity or something, whatever range you want, there's a significant portion of folks that are going to be PCR negative. So this is a little different than, PCR in or something like Ebola, where blood samples or whatnot may be able to be used to give you something. But so does that make things more difficult? It's just that
the false positives make things more difficult, and
false negatives in this case, yeah.
The false negatives,
right,
are going to make things more difficult. I mean, it's interesting. We may have to be doing a double, an initial test and then a backup test in the case of contact tracing, or have better tests. Even we just sort of not in the context of contact tracing, but for HIV, you can have a rapid test to screen, and then you confirm with something like a Western blot or something like that. So right now we're using tests that do have false negatives, and it's a problem.
Right.
But that's what we've got, and that's how
Right. But so that's what I mean with our best tests giving you a 30-40% false negative rate. How the heck would we be able to stand up an effective tracing program, or stand up an effective isolation program?
Well, if one of the two of you are my contacts and you had a positive test and you had a negative test, I would say, you're going to go into isolation. So you should probably self-distance, self-isolate for 14 days too, even if you don't have recoverable virus at that point. So I think there's going to be some sort of
clinical judgment,
and also sort of saying like, look, all of you are contacts with Greg who's had disease. Going to ask you just to limit your movement for the next 14 days. It's clear that the New Zealand public health response was using the same. Everybody's using the same tests, relatively the same tests.
Right.
And so I think even with an imperfect test, there have been countries that have been able to sort of figure out how to do this.
Could that be because, again, South Korea and New Zealand had outbreaks that were much, much, much smaller than anything that, happened in, say, New York, or in basically the entire United States as well. How many different places in the United States, how many metro areas have outbreaks that are way larger than what New Zealand has, or even what South Korea had? Are you able to do this when there are still a background of, say, even in a major metro area, say you have 200 new cases a day, right? Which isn't a lot compared to what New York and New Jersey Metro was doing. New Jersey and New York Metro were doing, I think they were at the peak, they had 11,000 new cases a day. Of course, in those cases, forget about any type of isolation, contact tracing. You're just doing mass mitigation, which is what happened. But at what level do you think we would need to get to make it such that the public health infrastructure, even if we stood up and added whatever billions of dollars more, at what level does it seem practical to be able to do? Because it seems like in New York City, for instance, right? If you have 200 new cases a day, 200 people, say half of them take the subway a day, right? And then you go back 1 to 3 days after they turn positive. And that seems like, my God, how many people must they have come into contact with?
Well, there's a bill that just got put into the Senate by Michael Bennet in Colorado and Kirsten Gillibrand from New York, which says they want to hire or support 1 million contact tracers throughout the U.S. Charlie Baker in Massachusetts just asked Partners in Health a few weeks ago to hire 1,000 contact tracers for the state. So people are getting started with large. I think in Connecticut maybe we had, we've had very, very few contact tracers,
right?
And they get recreated to go after lone tuberculosis cases and things like that. So there's going to have to be a massive human scale up, massive testing scale up. We are nowhere near South Korea or New Zealand. It's just we basically fiddled while Rome burned and let all these it's so deeply embedded now across the American landscape that tracking down all these cases, it's going to it's a lot harder now than if we had started earlier and done the right thing.
Right. I wonder, is it fair to wonder whether this is impossible to do, given how widespread it is? Meaning, each contact tracing. I know there's some numbers about you would need like some massive number just for each case. And also there's also the issue with not with. I guess we'll talk about this next, but the serologic tests, correct? Do you see the serologic tests helping here at all, or this is primarily going to be PCR based? Because of course the problem with the PCR test is that if you're negative today, that doesn't say anything about are you positive tomorrow? So are we going to serially test? It just I think the New Zealand, South Korea examples are given a lot, and it's wonderful. It's amazing that what they were able to do, but unfortunately, we can't go back in time. We don't have a way back machine to get back to their type of numbers. We have a problem in a 300 million.
Well, but I think we're in big trouble. Yeah. I think we're in big trouble, and I think there's a little bit of still sort of head in the sand attitude. Like the whole national discourse of the past week has changed from like let's keep at it to like 10 states are reopening and social distancing restrictions from the federal level are being the guidance is expiring today. It's not going to be renewed, and nobody's sort of standing up going, "What are you all crazy?"
Right.
The point is that we sort of don't care.
Well, is it in part driven by a mentality of like it's not possible anymore to get to New Zealand or get to whatever?
No, because I think both public health people and economists and lots of clinicians will say like we don't have a choice. I think there's just really no appreciation for the magnitude of the situation we're in, and the scale up is going to have to be immense, and we could still, we're still not talking about becoming, eradicating like New Zealand. We're talking about stemming the damage and mitigation at this point. There's a new piece up on the New York Times website about Georgia, saying Georgia went first and we failed. I mean, clinicians in Georgia are already saying like this is a train wreck, in slow motion starting to happen. They haven't reduced their cases there. Their testing data is terrible. So I think we're still in damage control, but the appetite for it at the federal level and among some states is so low now that we're in deep trouble, I think.
Yeah. We'll talk about what's your thoughts on antibody testing? How do you see the serologic testing? What utility do you feel that they may have?
Well, theoretically could be useful. Now it's like the Wild West. It's like the FDA allowed companies to self-validate and get these things on the market. So like the city of Chicago was importing 11,000 tests from South Korea that the FDA had never seen. And nobody knows what the sensitivity or specificity, the false positives or false negative rates are going to be for these tests. Nobody knows what SARS-CoV-2 immunity looks like. Is it like some of the common cold coronaviruses and has transient immunity, or are we talking about, maybe, the first SARS virus, which maybe has 2 to 3 years immunity? We have very little knowledge about how it's going to work and what it confers. There was a study that came out of China, and recapitulated by the study that came out of Institut Pasteur and the French recently, that there are people who have hospitalized infections who don't develop antibodies. A small fraction, but there's a not unreasonable size fraction of about 30-20% that have low titers of antibodies. And does that confer protection, or is there some other component of the immune system that's being responsible for this? So we have the basic and clinical knowledge lacking in terms of what antibodies do and what they do in terms of conferring protection in the context of disease. And then we have a whole sort of, Wild West of tests out there that have not been evaluated properly. We have no idea how they work, if they work. And then you have to figure out, like, what is this going to mean in terms of, if we had a perfect antibody test, we're going to create 2 new classes of Americans and people in this country who are, cleared and clean, and then the dirty susceptibles who are left. I mean, there's like really a weird dystopian future ahead of us, where these tests could be misused to sort of tell you if you can return to normal life, quote unquote, normal life.
Yeah. One of the issues seems to be with serologic testing that it's not exactly a chip shot to validate these tests, right? Because you need negative controls, and getting a negative control for this is not that easy, right? You need either to go back in pre-coronavirus history, pre-SARS-CoV-2 history, and find some serum and look there, correct? And you have to figure out seasonality wise when you're going to do that, because of course you're looking to see if there's cross reactivity with these antibody tests to other coronaviruses. Exactly. And so this is, seems really hard to figure out, what's a true negative and what isn't. And the issue, of course, seems to be with that is that, in order to broadly scale testing, like it seems a lot of folks want, you have to open up testing to a swath of the population that may have a relatively low prevalence of disease, right? So certainly some of the testing, I know the issues with specificity in terms of the various different various different serologic surveys that have been done so far. I get it. But assuming that some places do have prevalence, and I think a lot of, Natalie Dean, for instance, who's a really good epidemiologist, who's I've been reading her comments and stuff. I think there's some agreement, and correct me if I'm wrong, some agreement that you're probably in a lot of places in the country in single-digit prevalence in terms of how many people have it, right? Which is bad because you're really far away from herd immunity.
Yeah.
But it's also bad because, my God, that in order to get the type of test characteristic you need to test a prevalence of 4% and have that come up with a meaningful number is close to impossible. So, testing testing seems really, really hard to get right. Not for beyond the inability to have enough swabs and enough RNA extraction kits and whatnot. So how do you see us eventually being able to figure this out? Because again, I get the sense that these are unique problems that the world has kind of not faced before when it comes to these type, the things that SARS-CoV-2 is kind of throwing at us.
Well, remember, this is not my first epidemic, and I remember our problems with testing for HIV in the early. This is not unique in terms of low prevalence. Like we're a concentrated epidemic in the U.S. for HIV, and so very low prevalence among the general population, and trying to validate those assays. And so I don't think it's a totally new thing. I think we're just in such a crisis at such a large scale that it's hard to sort of figure out how to sort of keep our a handle on the epidemic while we're trying to deal with all these technical issues. I do think one of the interesting things that I've seen is that all these labs are retooling themselves to do a lot of this work, and they know it's not paying their bills in terms of what they're supposed to do for NIH or whatever. And I think the clinical and scientific community has been pretty damn heroic in terms of what they've done, both for patients, but also sort of, they just developed a saliva-based assay here for, I think it's a PCR. So I think people are trying their hardest to sort of throw themselves into these sort of technical and scientific struggles, while others sort of deal with the rest of the mess out there.
Greg, given those challenges, can you give us your sense of the, if we can call it the historical view, if we look at the next 2 to 3 to 5 years, and in light of what Sweden is trying to do, with some comments saying they hope to achieve herd immunity in the next, in Stockholm in the next couple of months, that sort of thing. Is it the hope that we can sort of, as much as possible, keep the numbers down until the vaccine is around? I mean, is that the one realistic hope? Because otherwise, it seems that the uncertainty, the lockdown, these things are sort of perpetuating, and it's hard to understand what criteria we're going to use to get out of this.
So I'm trying to keep a grip on my emotions lately, because I think ever since middle of April, when we were talking about liberate Virginia, liberate Minnesota, all this crazy talk about just sort of go outside, it's hard to see what the end game is here. I think the resources we're going to need for testing, tracing, and isolating is not there yet. The technical hurdles are there as well. And so we're in a situation where, you could see in 2 months in the summer that, more than half of the US states have sort of relaxed social distancing in a way that starts to feed a new epidemic. And I think the Natalie Dean article today with Caitlin Rivers at Hopkins, I think suggests that, if you want to count on herd immunity, you're talking several years and a lot of dead bodies in terms of our elderly and our medically already having underlying medical conditions. So yeah, basically about a week and a half ago, I realized we're not New Zealand, we're not even Italy or Spain. We're something that's fairly unique in creating a set of policies that are designed to perpetuate the epidemic and string it out for a longer amount of time. As crazy as that sounds, whether it's by malice or incompetence or sort of ignorance, it sort of doesn't matter, because I think it's just going to be, I don't know, I see 2 years stretching out in these waves of clinical crisis for hospitals, where you have another wave of people coming into the IC, into the emergency room, into the ICUs. My biggest fear is flu season. I remember in December we were talking here at Yale New Haven Hospital about how they were already full. They already had people in the hallways because they were over their capacity. Can you imagine if coronavirus strikes, in November, December here as flu season arrives as well? I think I don't think we've seen anything yet in terms of what's in store for us. I'm trying to sort of remain hopeful and focused on sort of what needs to be done. But I also don't want to be a Pollyanna and say like, you know, it's going to go away overnight. It'll be gone. You know, it's something that's here to stay.
Are you surprised by, I know I am, are you surprised by the fact that Florida, for instance, just as one example where you had a kind of one of these, a governor that was, how shall we say it, was certainly far more liberal in his views of what one should do. So, the beaches were open for for a long time in the midst of this epidemic, etc. Yet, we're sitting here April 30th, and it's hard. It's a massive state, right? I think 20 million is the population. They have 1,000 people that are dead. The number of new cases they have is still in that 200 to 300 range. Why are they not in the midst of a far worse situation as we kind of expected, 2 or 3 weeks ago when they were kind of not doing what everyone else was doing?
Well, one is I think there's spontaneous social distancing. People are afraid and are staying away from home. In the old days of the AIDS epidemic, there was a drop in sort of infections in the early years, and everybody's like, that must have been because of HIV prevention programs, but actually the curve of reduced sort of sexual contact happened before that because people were scared out of their wits. And so some of that's going on. I was actually talking to a Miami Herald reporter this afternoon, and I was looking on COVID tracker, COVIDtesttracking.com. I can't remember what the name of it is, the COVID testing project by the Atlantic. Data collection in Florida is terrible. They get a C and Georgia gets an A. So we're talking like, if Georgia gets an A and Florida gets a C in terms of data collection for just tests, we're in trouble, right? Also, there's an article in Newsweek this afternoon about how the coroner's office has been told they cannot release autopsy and death reports over the past week to 10 days. And so there's a little bit of sort of playing
a bit of fudging
with
perhaps,
the data in the state. But if maybe they've I think they considered keeping the lockdown in Miami and Fort Lauderdale and some of their big sort of high risk counties, Miami-Dade and others. Maybe that's been working. And I think the governor is not talking about lifting restrictions in some of those sort of high risk counties. Although, as I said to the reporter, if the rest of the state is open, I don't understand how you're going to keep people from going from one place to the next.
Right.
But yeah, I mean, the Florida example, I do think some of the data is showing that the epidemic is moving to rural and more southern states as it sort of starts to wane in some of the sort of northeast metropolises.
Yeah, really, really interesting to see what kind of happens. The other thing, I wanted to talk about, especially given your background in AIDS, is the data that just, well, I shouldn't say that. I said, well, whatever was leaked by Dr. Fauci kind of yesterday in regards to remdesivir. What do you have any? I know from your Twitter account you have some concerns. You want to discuss some of those?
I mean, really, people. I mean, I've known the man for since I was in my 20s. I mean, I think he's done a lot of good in terms of infectious disease over the past 30, 40 years. But to do it in a press release, it just, there's no data there. It's just, they're saying like, here's what we saw, 30% reduction in time to recovery. There was no, the survival benefit wasn't statistically significant. And everything is going to go to standard of care and the rest of the trials from now on. And, it's, who died and left you king? It's just like, the point is we need to see the data, and, so New England Journal needs to, the investigators need to wrap it up and send it into New England Journal or to wherever they're going to get it published so we can all see it. I mean, there's some endpoint outcome switching, which probably could have been totally innocuous and benign, but like, we got to know this is a significant development,
right?
In light of the Lancet publication, which didn't show a superb effect for the drug. I mean, maybe we're back at the level of AZT in the early days of the epidemic, something that has modest or small effects. But like, we spent 10 years arguing about whether it worked at all.
Right.
After the first trial showed an 18-to-1 or 19-to-1
death difference. Yeah.
Which nobody believes 40 years later, but you grasp at straws in times like this.
Right. No, AZT, but that's the interesting part is that he Fauci himself kind of compared what we're currently going through to when AZT initially came out. Clearly he feels the weight of the controversy with AZT, right? The AZT trial, is a blind placebo trial, RCT, where 19 people in the placebo arm ended up dying and only one person. And then, of course, the longer term data showed that, not done here, done in Britain or whatnot, showed that,
France too.
Right, in France, over time, that there was you kind of lost that mortality difference. And it seems like, or I mean, again, you tell me if I'm wrong, but it seems like from reading what Dr. Fauci said, and Ellen Tadaldi and Dr. Moyer here, infectious disease at Temple in North Philly, fantastic training place. That's where I trained, and so anything I know about HIV, I know from them. But it seems like, the idea, the reason that folks stopped responding to AZT was mutations that would happen, and so you wanted to try to hit HIV, hit the virus from multiple different angles, so not allow it to that chance to kind of mutate and escape the effect of AZT. And AZT still is part of a variety of different cocktails, correct? So is it necessarily,
I mean, not so much, but yeah.
Is it the case that that you have a certain burden as a trialist, given that there's a significant difference that you're seeing 11 days versus 15 days in terms of time to recovery, and that there's a trend towards mortality? Do you want to continue the trial until there is a mortality difference, or do you want to have a guy like Fauci, who's super experienced and has been around the block, kind of look at it and say, all right, this is enough for me. I don't need to continue people in a placebo arm, because there's the ethics of kind of continuing a trial. There's a difference being seen.
Well, the data safety monitoring board made the call, not
right. Sorry,
so
yeah,
and I'm sure they, saw like the benefit in terms of time to recovery was significant. They thought, we got to stop it. We argued around AZT about whether it had a survival benefit for even past that initial trial for a long time. And so I think it was a no-win situation. That the DSMB probably had to stop it, but like, who knows what this data is going to say, and who knows if it's going to pan out. The weird thing is now everything has to be tested against it, which sort of is like really on the basis of one trial that showed a modest effect and no survival benefit. I don't know. I mean, who knows? We'll see. I mean, hopefully we learned our lesson from the AZT years and don't want to get stuck with.
What would you have done differently in terms of the AZT years, in terms of would you just continue the trial longer, or?
Well, with the AZT study, it was less of a question than it was for DDI and DDC and D4T, the sort of, children of AZT and like the sister drugs. We just kept doing it on these surrogate markers and never looked at survival. This is why the survival benefit is going to be important to sort of clarify, because nobody knew if AZT extended life. Like you could get, for D4T or TDI or DDC, you get 7 more T cells, and that was how they got approved. And it's like, this is going to be a drug that, could be given to millions. Who knows what Gilead's going to charge for it? There'll be pressure to sort of reformulate it for something oral so that maybe it could be used for PrEP. I mean, a lot of money could be invested in this drug without sort of really understanding what the clinical benefits are in terms of survival of patients.
How would you design the trial different? Is there a different way you would specifically design the trial to kind of get at it, or would you have done the AZT trial differently? I mean, I'm trying to get it. How does one? It is hard. You have a novel pathogen.
No, I think the AZT.
How do you do it?
People said with the AZT trial, doctors could guess who is on
placebo, right,
on the drug by mean corpuscular volume or something else. In this case, I mean, what are you supposed to do? I mean, Yeah, I don't know what to say. It just, I'm not going to second guess the DSMB until I see the data, but we can try, to try do some sort of newer kind of tools, looking at the observational data to see if we can retrieve a survival benefit, using G computation and some sort of tools of causal inference on observational data. But the chance to get that survival endpoint now is
right. Although in defense of the decision by the board, the DSMB, this is an acute illness, short term. So I think there may be more value to the surrogate endpoints like, time of the ventilator and time to discharge. I think it makes more sense to know that this will probably translate into a benefit in mortality, as opposed to having to follow people, for years who have a chronic illness and that is not eradicated. But it's challenging, yeah.
No, I think this is the fights we had back then too, even in the context of, people time from diagnosis to death in the old days was it wasn't like this, but it was, it was pretty quick.
Mm-hmm.
But it is a weird thing if it's a small to modest benefit in terms of time to recovery, and it doesn't sync up with a survival benefit. I don't know. Here we go again. We're going to have a combination therapy trial against the single. It's going to be, it is an acute disease. Yeah. We'll see.
But
we're just going to get access to this too, because there's not going to be enough to go around.
Yeah, that's true. Access is always an issue. But the AIDS story is an amazing success, correct? I mean, to think about where we are now relative to where we started in 1981 or whenever that initial report of five folks
no vaccine,
who had it.
No vaccine, and it took us 15 years to get. Nobody sort of really thought we were going to survive until 1996, until we saw, the protease inhibitors. So it did take 15 years to get to that place.
Right. Right. Yeah. Well, so Dr. Gonzalez, any other questions, Michelle?
No, I think that was very informative and clearly you brought out the challenges that we're facing.
Yeah, it's going to be. Nobody would have thought in December that we'd be living in these interesting times.
Yeah. Really unfortunate, but hopefully we muddle through somehow. All right, Dr. Gonzalez, thank you so much. I really appreciate you coming on.
Thanks to both of you.
All righty, bye-bye.